video. That just helps everybody with bandwidth during the, and it's a bit less of a distraction. Please click on the chat box to ask questions or comments. We will attempt to answer those as we go, but also we'll select some of those, select them to answer at the end if we can't do it or if we think there are more general issue in relation to it. And if you have a question when we get to the Q&A session, please use either the raise your hand function or the comment box. We'll be monitoring both, hopefully, during that period of time. Just a reminder that you can pin a speaker's video so that the others don't flash up on screen if you find that distracting, as the case may be. So very briefly then, for those, hopefully the few people online who have not heard about the Australian Prevention Partnership Centre before, we are a collaboration funded by and only exist because of the funding between our partners, the National Health and Medical Research Council, the Australian Government, the ACT Health, Cancer Council Australia, the New South Wales Government, Wellbeing South Australia, the Tasmanian Government and Vic Health. And we're based at the Sachs Institute, but we're a multi-institution organisation with over 15 universities and research partners across Australia. And during our period of operation, we've involved several hundred of researchers, both within and outside, within the university sector and outside the university sector, within our funding partners and others in relation to this. Briefly, we were set up to look at the whole issue of translation of research. That we summarise our work as at a glance to say that we try and identify the new ways of understanding what works and what doesn't to prevent chronic disease, and we work and then we want to work out how, and the way we work is through generally through some form of co-production between academic researchers, health system practitioners and policymakers. And as I've already described who we are before, as I say, based at the Sachs Institute, but actually being a coalition of a whole range of different research partners in relation to this. The Prevention Centre has undertaken a number of modelling works to forecast and compare the outcomes of alternative preventive policy and program scenarios. We've done specific models around alcohol, obesity and tobacco. And of course, the value of the simulation model of these has received a lot of attention during COVID-19, but our work has commenced a long time before COVID-19 in this regard. In fact, it grew out of a conversation between Lucy Resnick, the other co-director of the centre, Sally Redman and Joanne Atkinson, who will take over from me briefly. And it was the origin of this was about a better way of trying to translate research findings into a way that could inform decision making in relation to this. So this project, as I say, has taken what we've learnt from all those other projects, single agent projects that we looked at, and for the first time in the chronic disease prevention space, brings these together, combines risk factors and explores their interactions, because we know these things don't work independently. People who smoke and who smoke tobacco are more likely to have other risk factors like low activity levels, for example. So these things work together, and the diseases that they create also interact with each other. And so what we're trying to do here is address the higher order policy questions about the combinations of risk factors and how interventions for these might provide the best types of outcomes. And in particular, where we've got to now, we're starting to add the economic component to this so that we can actually look at the impacts both economically and where the sort of best bang for buck come from. So this is a progress report for the Prevention Centre's funding partners and guests at this point in time. It's an update on work which is coming really to the pointy end, and that's why we've come with this sort of early sort of penultimate version of where we are, but taking it to our funding partners and others who are interested to try and just finesse and to get your feedback, which will help us finesse the model as we go into the final stages with this. There is more work to be done with the model, we know that, and that's why there is this opportunity to take your feedback and incorporate it in what we do. Our plan is that the GoHealth model will be launched in the first half of next year. The modelling team are live with us today, but due to the size and complexity of the model, the technical part of the presentation has been pre-recorded. We did try it out in advance, and we decided that that would be make for a more efficient use of the time that was available, but the team will be on live to answer your questions afterwards. So I'd now like to hand over to Professor Joanne Atkinson, who's been with this project since the beginning, and as I said, was one of the people who really formulated the whole notion of where we would go with our modelling work in the Prevention Centre. So it's a great pleasure to hand over to Joanne to introduce and get the formal presentation started. Thanks, Joanne.
Thanks very much, Andrew. So just to give you some broader context for this work, as Andrew mentioned, over the last 5 years, we've developed separate systems models to support decision making on how best to reduce harmful alcohol consumption, smoking prevalence, childhood overweight and obesity, diabetes in pregnancy, and deaths from cardiovascular disease, to name a few. But important feedback from our national and state policy partners reminded us that tackling different risk factors or different disease outcomes separately in our models really fails to look at the problem of how to prevent lifestyle-related chronic disease systematically. And it misses an opportunity, in fact, to inform how best to invest in a targeted, coordinated way across the portfolio of risk factors to achieve the greatest impact. So the team set about building a single systems model that includes this broad range of risk factors that contribute to a broad range of lifestyle-related chronic diseases, and allows policymakers to determine how to invest more strategically to reduce the chronic disease burden in Australia. So for the first time, this model allows us to look at what combination of risk factors, at what scale, targeted at whom, at what time, and for how long represents the best strategy to achieve the greatest reductions in Australia's burden of disease. And Danielle will speak more on what the model can do to support chronic disease policy and planning. But also the aim of this work was to really help us as a public health community to make a more united and compelling case for investing in chronic disease prevention. So a range of economic outcomes have been integrated into the model, which Paul will summarise a little bit later before we move on to the Q&A session. Next slide, please, Jackie. So mapping, quantifying, testing and validating a systems model of the complex causal interrelationships between the common risk factors for chronic disease based on both the global and Australian burden of disease data was a hugely ambitious undertaking, but one that did not deter this small team of talented, energetic and dedicated researchers keen to push the boundaries of decision analysis through the use of complex systems modelling and simulation. And this team includes Dr. Danielle Curie, who is the lead and senior systems modeller with decision analytics at the Sachs Institute. We have Haitham Taha, who is also a system dynamics modeller with decision analytics at Sachs. And both Danielle and Haitham have done really the heavy lifting on model development. Dr. Stuart Bretnall is a biostatistician working on the project and is with the Sachs Institute. Jackie Davison, of course, research officer with Decision Analytics and the Prevention Centre at Sachs, has been the project manager on this research. Of course, many of you will know Jayatri is a senior research fellow at Deakin Health Economics and is also leads the economics of obesity stream within Centre. There's Paul Croslin, also a Senior Research Fellow with Deakin Health Economics, and Paul and Jayatri have really led the thinking and the provision of estimates for the economic component of the model. Importantly, we've also benefited from the guidance provided by a range of expert advisors, including most recently Associate Professor Stephen Begg, a talented epidemiologist and the La Trobe Rural Health School's Director of Research. Also, Emeritus Professor Rob Carter from Deakin Health Economics, who contributed to the initial vision of this work, and Dr. Jeff McDonnell and Professor Mark Heffernan, whose decades of experience have contributed to providing a solid foundation for this dynamic modelling work. I, of course, can take very little credit for this work, having merely occasionally steered the ship while the team have done the heavy lifting. So without further ado, I'll hand over to the team, starting with Danielle, to talk about what this modelling can do.
Thank you, Jo, for that great introduction. Just before we start, just because there's been some late additions, I just want to give a few reminders. So if you don't mind, just to help the meeting go a little bit smoother, if you don't mind staying on mute and turning off your video until the question and answer session. If at any time you lose the presentation, just check the bottom row of your gallery to find the presentation screen. So double click on it to bring it to the top, and that will enlarge it for you. There's also at the three dots menu towards the top right-hand corner of your screen. If you're on a PC, I'm not sure if it's a Mac, but anyways, there's three dots menu, and you can choose focus, and it'll bring the screen to the presentation screen to the front. If you have any questions, please start writing them in the chat panel. Our moderators will keep note of them, and if you see a question that you like or that you agree with, you can endorse the question by liking it. Alternatively, if you'd prefer to ask a verbal question, just raise your hand and the moderators will note your name, and we'll try and get to you in the order that people raise their hands towards the end of the presentation. So that's the best way to get a hold of us. And so without further ado, see if I can get this to go to the next slide. Not sure if I can change the slide to Jackie. There we go. Okay, so let's start from the beginning of this. And Jo and Andrew have given a really good conceptualization as to why the project was there. But really kind of there's a couple of concepts that underpin why we did this. And a lot of it is highlighted in the Australian Burden of Disease study that the AIHW has done wonderfully. And some of the things that came out of this AIHW study is that Australians are suffering more burden from living with illness than from premature death. So illness is causing great burden on the people of Australia, and a non-negligible portion of that burden is preventable due to modifiable risk factors. Or due to the modifiable risk factors that we've included in our study. So basically the ABD and the Global Burden of Disease study show us, or they tell us, that the burden of disease in Australia is big. It's partially caused by preventable risk factors, and it's contributed to by a multitude of interconnecting risk factors and diseases. So burden of disease studies like these generally show us a snapshot of time. So the ABD shows us snapshots from 2003, then 2011, and then 2015. And we're quite happy to know that the 2018 study is currently underway. And so the ability to understand and measure modifiable risk factors is crucial to reducing the chronic disease burden, which is why these studies are so important. However, because they're this kind of snapshot effect, it can really only take us so far, and when we want to understand what's likely to happen in the future and then modify what's likely to happen in the future. Next, Jackie, please. Wonderful. And so where is the knowledge gap here? Well, the knowledge gap is kind of in two different areas. So the tools and evidence decision-making tools that decision makers currently use either give us these really important but infrequent snapshots, and they're retrospective snapshots of kind of what is happening within the health of Australians, or as we kind of see in the kind of purple square there are studies that do look at the risk factors and diseases and how they may go into the future, but they often look at them in isolation. So historically, we know that the total burden has declined by 11% since 2003, but not all diseases and not all risk factors contribute to that. So some are increasing, some are decreasing, some are stable, and not all age groups have the same declines or the same trends, which really makes a complex picture of how risk factors and diseases are changing over time. So the ability to understand and measure modifiable risk factors is really crucial to reducing chronic disease, which is why studies like the ABD and GBD are so important. And not just for this model, but for that ongoing decision-making process and policy analysis. But again, those can only take us so far when we want to understand what's likely to happen in the future, because we need to know where the trend is going in order to make those changes to try and increase the health of Australians. And there is an abundance of clinical evidence that tells us the relationship between risk factors and disease, and that's really, really important. So for example, the links between body mass index and ischemic heart disease. But it also tells us that there's links between risk factors themselves. So links between body mass index, strongly linked to diet, blood pressure, among other risk factors. So there's this interconnection between the risk factors as well as risk factors of disease, and then they're all changing differently over time. Next. Wonderful. So then there's one more part of this picture, and it really is how much is all of this worth? So after accounting for the disease burden, we also need to be able to account for the other costs in society and make that link back from risk factor prevention all the way through the healthcare costs and productivity, because it helps us measure, we can measure kind of health changes not only in the actual health of Australians, but how much it costs Australians in terms of the healthcare system and productivity. So we have a picture here from the Vic Health study on productivity in 2008, and the estimated value of risk factors and productivity loss. And so this is one of the studies that kind of helped lead to this project. Wonderful. So this brings us to. Oh, go back. Sorry, Jackie. Can you go back one? Yeah, so this brings us to the GoHealth model. So the GoHealth model tries to fill that gap. Sorry. It maps the causal mechanisms between the risk factors and the diseases, as well as the risk factors themselves, and then measures the cost of this burden, both in terms of cost to the health sector and societal costs, as well as the actual health costs in terms of burden of disease and death. So here you can kind of see some of the risk factors that we've used or we included in the model, as well as the diseases. But I'm going to go through those in a little bit more detail in a moment. And then I'm going to pass over to my colleague, Paul, who's going to talk more about the economics. But first, what do we hope to achieve? So the point of this model is to help us answer what-if scenarios. So it's not intended to predict what the future health of Australians is going to be, but rather to test these what-if scenarios that can be used as a policy tool. So for example, what if we reduce the number of people with a BMI over 30 who are between the ages of 40 and 60 by 10% over the next 10 years? So that's kind of a policy question that, what would happen if we did that? So what impact will that have on the disease burden of specific diseases? But also, what impact will that have across a range of different diseases? So on one hand, we can look at it, what impact will reducing BMI have on ischemic heart disease, for example? But we can also look, what impact will it have across diseases like ischemic heart disease, as well as different cancers and stroke and kidney disease? And then further, we can look at what impact will this reduction in BMI have on the prevalence of other risk factors. So if we reduce BMI by 10%, how will this affect the people's blood pressure as well as their blood glucose, which then goes on to what would be the resulting economic benefits of these changes at the national, state, and household and societal level. So it really kind of goes from there. And then overall, what would be the impact if we combine this effort with other efforts to reduce risk factors? Because often when we're doing an intervention, we may do an intervention that's targeted at ischemic heart disease, or it's done through the lens of ischemic heart disease in terms of reducing BMI, for example. But what if we look at it, how would this affect the other diseases and the other risk factors and other costs? It kind of puts all of these multitude of things together. So once finished, the model aims to produce a useful online tool to understand and effectively communicate the expected impacts of potential prevention investments before they are implemented in the real world. So this is just one of many possible scenarios or questions we could use this model for. So let's just take a quick look at and test just one of these questions. But first I'm going to go through, there's a bit of a lag, sorry. Next slide, Jackie. Just go back, yeah, go back one, please. Back. Back. Beautiful. So these are the risk factors that we've included in the model itself. And we recognize that there's more risk factors out there. More were included in, for example, the Australian Burden of Disease study. But we chose these ones because they're individually the biggest contributors to chronic disease, particularly in the adult population. And they're also modifiable. And many of them work in combination to contribute to disease. There's also relatively good population level data for most of these risk factors. However, differences by age or sex or their consistent trend over time is not always well described. So we're including high blood pressure, high cholesterol, low physical activity, tobacco use, low fruit consumption, low vegetable consumption. So those are our two dietary ones. Alcohol consumption, high BMI, and high blood glucose. And in terms of the diseases that we're including, these are the diseases that we have included. And we chose them because they pose the greatest burden that can be attributed to our risk factors that we selected. So they may not be all of the diseases that pose the greatest burden, but they're the diseases that have the highest link between preventable burden and the disease itself. So according to the AHW in 2015, these diseases and their sequelae account for kind of more than 25% of the total burden of disease. So there are two notable big chronic diseases that we've left out right now, and these are namely dementia and low back pain. These two are usually in the top 5. However, their relationship to the modifiable risk factors that we have chosen is less clear, so we're not including them at this point. Similarly, some other big counts for disease burden are things like injuries, falls, suicide, and other mental health disorders. These are currently not included in the GoHealth model of chronic disease. So we've just focused on a select few really to show how this can work. And so within our diseases, if we just take ischemic heart disease, for example, we're not just looking at the disease itself, but within ischemic heart disease, there's a number of sequelae, so kind of sub-conditions. So for example, in this one disease, there's angina pectoris, acute myocardial infarction, as well as heart failure. And then for each of those, they're kind of sub-broken into asymptomatic, mild, moderate, and severe. So we really have done a deep look into a whole bunch of different disease groups, different stages of the disease and different intensities of the disease to really capture the picture of disease. And so before we go any further, I'm just going to quickly talk about the measure that we used. And I'm sure many of you have already seen this before, so if this is something that's familiar to you, I apologize in advance. I'm just going to spend a minute or two on it. But for those who aren't familiar with the concept of the disability adjusted life year, it's a measure that's used for many burden of disease studies. And really what it does is it measures the overall burden of disease calculated by adding two things together: the years of life lost to premature death. So really that's just the difference between what your life expectancy is at time of death and how old you were when you died. That plus the cumulative years of life lost to disability or disease. So when you have a disease or a disability, there's a kind of a disability weight attributed to that. So that's the degree of severity of disability or how debilitating that disability or disease is to your life. And so throughout people's life courses, they have different diseases, different disabilities, which can be chronic or acute. And we're added up over the life course, and then we take snapshots across the population. So that's the key measure that's used to model the burden of disease itself. There's other measures like QALYs and healthy adjusted life expectancy. They're commonly used in health policy. However, for this particular model, we needed to calibrate it with other historical data and use the best evidence we have, which is the Australian Burden of Disease study and the Global Burden of Disease study, who both count DALYs, so we've joined that group. Wonderful. So if we think about the last slide I showed, which had the life course of one person, well, if we look at those life courses across the entire population of Australia, people are at different stages, people die at different ages, have different disabilities. When we take studies like the Australian burden of disease and the global burden of disease, it provides a 1-year snapshot. And so it tells us what's happening in that 1 year across the entire population. So that's what a DALY is, looking at the whole population, and in a 1-year period of time, what is the burden that is currently exists within the population. So that is just kind of a refresher for everyone who hasn't heard of the term DALY. So that's what we're using if I mention DALY. So I apologize if there's a bit of jargon in here. Let's move on. Wonderful. So I'm going to take about 2 minutes before I hand it over to Haitham, just to explain how the model does this, because you're thinking, how do you combine all of these risk factors, all of these diseases, into something that tells us something? So we have our GoHealth model up here, and we're going to use an example of high cholesterol and ischemic heart disease. So if we take our risk factor of high cholesterol, what the model does is it creates a curve that looks at what is the proportion of the population that's at each different level of the risk factor. So some people have low cholesterol, and they're kind of in this nice green section. And some portions of the population have high cholesterol, and they're over here in this yellow and red section. And you can spread the whole population amongst this curve. So basically, the y-axis is percent of the population, and the x-axis is the intensity of the risk factor. We also know from the literature that there's a threshold. And people who are below the threshold don't have, their cholesterol doesn't pose a risk to that, of developing that particular disease. But individuals who are over that threshold, who have high cholesterol, are at risk of developing a number of different diseases. So we take this idea after we've spread the population out across the distribution, and then we look at the disease itself, once we go into the model's disease section, and then we ask, what level of risk does each of those specific levels of high cholesterol pose? So again, we just take this intensity of the risk factor. As you get higher and higher cholesterol, it poses a higher and higher risk of developing ischemic heart disease. So the model uses these risk curves and combines the risk curve with the population distribution to help us answer the question, how much of ischemic heart disease that is present in the population can be attributed to high cholesterol? But we know it's more complex than that. We also have, so it basically answers that. If we look at how much of the burden is high IHD, how much goes to high cholesterol? But we know it's more complex than that. We have to control for the effect that other risk factors have on cholesterol. So for example, things like BMI, blood glucose, and fruit and vegetable consumption, those control what your cholesterol is. So as those go up, high cholesterol goes up. So we need to control for that relationship and account for that relationship. But we also need to control for it the other way. We know that cholesterol, having high cholesterol, can cause other risk factors to go up themselves. So for example, the higher your cholesterol, the higher your risk is related to your blood pressure. So we can create this kind of matrix of factors that affect high cholesterol as well as factors that high cholesterol affects. And that gives us the total burden that we can attribute to cholesterol in terms of ischemic heart disease. So I hope everyone is following. But if we're going to take that start, and let's go to the next section of the model. So we have that proportion of ischemic heart disease that we can give to high cholesterol. We bring that in, and but we also have to calculate how much of BMI attributes to ischemic heart disease and how much of blood glucose. We take all of those factors, we combine them together, and then this gives us a combined contribution of all the included relevant risk factors to the incidence of the disease in our population. And we do it age and gender specific. So we take that number, we bring it into the disease specific section of the model. So for example, this is heart failure related to ischemic heart disease. So we've taken that into the model. We also have to know and account for the fact that there is a part of many diseases that's not contributed to by our selected risk factors. These could be genetic things or just other risk factors, air pollution or ethnicity or age or those sort of things. So we section out that amount, and we're just really worried about or concerned about the part that's affected by our risk factors. And that number changes the incidence of the disease, which lets us know how many people in the population have it. Then that number changes by factors like the remission rate of that disease, the rate at which people die from the disease, as well as with the disease, as well as how people age. And all of this together tells us how much of the disease we have in the population. And then we use those disability weights and we multiply them by the severity. So we figure out how much of heart failure, how many people who have heart failure have severe heart failure or moderate or mild. And then from there, gives us the combined disability that we can attribute to this disease, which we bring down and combine it with the other sequelae for that specific disease. And we combine all of the diseases within our model together, and that gives us the total burden of disease for all of the risk factors. Whew. Give you a second to kind of process that a little bit. It's quite complex, and I recognize that. But that's kind of the nuts and bolts of how the model works, what's happening underneath the hood. So now what I'm going to do is I'm going to pass over the baton to my colleague Haitham Taha, and he's going to work you through the interface of the model as well as how the model works and what some of the results are.
Thank you, Danielle. Hi, everyone. I am Haitham Taha. I am the system dynamics modeler for this project. I have prepared a short video that describes how the model might run through an online dashboard or interface. We show you some scenarios we have tested to demonstrate its capability, but please remember that these results you will see are illustrative only. For now, we are only demonstrating 3 risk factors and 2 diseases linked to our population model in this video due to time constraints today. However, once this is finished, all the 16 diseases and 8 risk factors will be linked up. Thank you. Now I'm sharing the screen for the video. Sorry, I was just like just turn on the sound. Okay. Okay, just a minute. Sorry. In this video, the GoHealth model interface and its features. This interface is the visual representation of the GoHealth system dynamics model. Currently, the model is comprised of many sections that run in the background of this interface. These sections are a population model, 10 risk factors, 16 diseases, and 17 economic sections. Now let's get into the interface. This screen shows the main dashboard. In addition to this dashboard, there will be model information provided in the About tab. Other tabs will be provided, like risk factors and disease sequence control panels, in addition to economic dashboard. This is shown in the left side of the screen. The GoHealth model interface provides the ability to control and include one or more risk factor at once to design scenarios. In this section, we have switches to include the risk factor. In addition to a knob to control the risk factors as desired. Also, the user can select the starting gear of the assumed scenario and gears to achieve the scenario target. A scenario is the change desired and assumed by controlling the risk factors. In this right section, the output of each simulation can be presented as graphs over time or tables for better viewing. For presentation, 5 different simulated scenarios were conducted and are ready for viewing. However, later, I will run two scenarios to present how the user can interact with the GoHealth interface and simulate the desired scenarios and its outputs. The 5 scenarios are the base case scenario compared to 4 reductions of 1 or more risk factors, as presented in the bottom of this graph. In this screen, we can toggle between tabs to explore the model output. The disease burden tab shows the YLLs and the YLDs output of 2 diseases, ischemic heart disease and esophageal cancer. The model can estimate the combined DALYs for all included diseases, view and compare the output of several scenarios in this combined DALYs tab. This comparative graph shows that greatest DALYs reduction was a result of controlling 3 risk factors. The model can estimate and view the reduction in DALYs achieved by each proposed scenario for included diseases. Here, we can see the final reductions marked by the minus sign in DALYs for ischemic heart disease, esophageal cancer, and combined for both. This is useful to view the effect of a risk factor on all its linked diseases. In the economic burden tab, we can view the reductions achieved by scenario in many economic measures related to disease burden. As an example, the economic burden of ischemic heart disease was used. In this tab, the allied health cost reductions per each scenario is viewed in this table. Similarly, we can include other economic measures of cost, like cost reductions in productive years lost, and its value by different scenarios simulated in the model. It's worth noting that we included 2 diseases here for presentation and illustrative purposes only. The burden of all model diseases and its economic burden can be added into the GoHealth model interface. Now I will run 2 simulations to present how interact with the GoHealth interface and simulate the desired assumed scenarios and its output. The first simulation will be base scenario, the business as usual, or the current state of the system. The second simulation will be the assumed 25-point reduction in BMI risk factors only, to show the capability of the model in serving the what-if analysis. To run the simulation, the user needs to use the lower control panel here, the play, pause, stop, and reset buttons to control the simulated progress. The reset button restores the model to its original state, the business as usual state, to clear the effect of the previously assumed scenarios. The original runtime of the model is from year 2011 to 2040. However, we present it here to year 2030 for quicker runs. Now, to run the first simulation, the business as usual, we only need to click the play button. Now the model is running. The runtime of the model depends on the size and complexity of the model. In this model, the simulation speed is as expected because the model size is huge, very complex, and includes many sections. Now, after the simulation is complete, we can view the output. In this tab, we see the estimated YLLs over time, evident by this line in the graph marked as newly added run number 28. For presentation clarity, here we show 10 years of simulation only. And to clearly show the difference in the scenarios, we present this graph to show the last 2 years of the simulation. In this graph, the output of the combined values is presented as points. Now, in the second simulation, a reduction in BMI only will be assumed. The user can do that by switching the BMI on and specify the reduction value desired by changing the knob. For this simulation, we will choose 25% point reduction for BMI only. Once the settings are selected, the user can click Run to start the simulation of the selected scenario. We must wait to see the output. We can see the simulation progress in this bar, and a new line is showing in the graph as run number 29. Now the graphs show the comparative output between scenarios we conducted in the model, the business as usual, and the Again, we can view the comparative results in the output tabs for disease and economic burden. The user can choose to add another risk factor or explore the output of reducing another risk factor using different reduction assumptions. There is a great flexibility in scenario design that can be achieved through using this GoHealth model interface. Thank you. I am happy to answer your questions about the model in the question and answer sessions. But first, I would like to pass on to the next presenter, Paul Crosland. Thank you.
Thank you, everyone. I'm passing now to Paul.
Thanks, Haitham. All right, good morning, everyone. The purpose of this particular presentation is to explain the economic measures that we've included in the model. So I'll be touching upon what they are, briefly explaining the data sources that informed them, and having a look at some of the output that the model can produce. But firstly, I'll introduce these economic concepts by considering an individual with the risk factors that we're interested in and the economic costs that are incurred as their disease progresses. So for this example, let's call this individual Paul. Paul used to be quite fit and active, but as he heads into his 40s, he's not so active and his plant-based diet goes out the window. So due to a combination of personal circumstances and environmental and social influences, Paul develops an unhealthy weight and also high cholesterol. So these risk factors cause atherosclerosis of the arteries and ischemic heart disease. However, this goes undetected until a myocardial infarction results in stents. So up until this heart attack, there's been no real economic impact up until this point. But now there's a few different economic impacts that occur. So the first is during the acute phase. So here we have an admission to ED. We have an admission to hospital for the procedure itself. And so there's various costs involved in that. And then you've got the fact that the hospital might be a public or a private one. After the acute phase of treatment, there's ongoing costs to do with going to see the GP, going back to specialists on a regular basis, and medications that he might be prescribed that are on the pharmaceutical benefit scheme. And also during this time, he has to take some time off work, both during the recovery phase and also to go and see these medical specialists. And so this is the second type of economic impact here, which is temporary absences from work due to the illness. But after that, he does go back to work for a few years on pretty much a full-time basis, but then encounters a stroke 5 years later. So because of this stroke, he can no longer work and exits the labour force. So here we have a third economic impact, which is not being able to work for the period of time between the date of the stroke and when he otherwise would have normally retired. Due to Paul's ailing health, he then dies a couple of years later. And where we have the fourth type of economic impact, which is the lost year's work between the date of death and when he otherwise would have retired. So there's 4 economic measures here, and so I'll go through some of this jargon here. But these are the 4 economic measures that are currently included in the model. The first is healthcare costs, and I guess this is fairly straightforward because it's the cost of any resources that are used in the provision of healthcare services, whether that's diagnosis, treatment, rehabilitation, or surveillance after the disease. And this was informed by AIHW's disease expenditure work, without which most of these healthcare cost estimates wouldn't be possible. And the reason that this data from the AIHW is so useful is because consistent methods were used to inform these estimates, as opposed to getting the cost of diseases from a range of different studies that might have used different methods. The second economic measure is absenteeism. So this is the name that we give to the lost productivity due to the absence from work on a temporary basis. And this was informed by a new analysis of the National Health Survey data, where we linked days off work to the diseases. The third economic measure currently in the model is participation in the labour force. And this is no longer being able to be unemployed on a permanent basis up until normal retirement age. And so this is otherwise known as early retirement due to illness or injury. And this is informed by our analysis of the National Health Survey data again, but this time linking employment status to the diseases of interest. The fourth economic measure that we have in there is lost productive years due to premature death. And this can kind of be thought of as a variant of the years of life lost, which Danielle spoke about earlier. But here we're only concerned with those years between the age at death and normal retirement age. And then we apply a financial value to this to estimate the productive value of those years lost. So what I'll speak about now is a demonstration of some of the output that the model can produce. But it's worth noting that one of the challenges that we've encountered with this model is the sheer amount of output that it produces. So if you think about the various health outcomes that Danielle spoke about and the economic measures that I just went through, for each age and sex, and for a variety of all of those different diseases and all of those different risk factors. And then within the economic measures themselves, you've got the various areas of expenditure and then monetized and non-monetized measures for each of those types of economic impact. There's some decisions to be made about which ones of those you put into the model interface and which ones you present as results. So what I'm going to show you next is just a small sample of this output for one single disease and the 3 risk factors that are linked to it. But the model can produce much more detailed data than this. Okay, so what we have here is an estimation of healthcare cost savings related to ischemic heart disease for 3 scenarios of risk factor reduction. And there's a few things to note that are worth noting within these results. So the first is the final cumulative value. This is all the final cumulative value at the end of 15 years, which is relatively short for a prevention kind of time frame. But the model can produce this information on a yearly basis, so you can see where the healthcare cost savings fall over time, if that's of interest to you. But then you need to make decisions around whether you're interested in total expenditure or just a particular area. The other thing to note is that these figures are for demonstration purposes only, because we're still ironing out certain facets of the model. So don't go quoting these figures for decision-making purposes just yet. And the other thing to note about this table is, I think, one of the key advantages of the model, which is the presentation of costs by area of expenditure. So there may be areas of expenditure that are of more interest to people on the call than others. So, for example, we show the cost savings that accrue to the public hospital system, for example, towards the bottom of the table, which is largely funded by the states, and also the areas of expenditure like GP services and the pharmaceutical benefit scheme that's largely funded by the Commonwealth. This table also demonstrates another feature of the model, which is the fact that it can do scenarios of multiple risk factor reductions. So if we look at the first column there, we've got the healthcare savings due to a reduction in BMI across the population, which is $100 million across the entire healthcare sector. Then when you add a reduction in blood pressure on top of that, you get a marginal increase of $20 million of healthcare cost savings. But then when you add cholesterol reduction on top of that, because of the way the model calculates the interaction of the different risk factors in the background, we now have quite significantly increased healthcare cost savings of $287 million because of risk factor reduction occurring concurrently over time over those 15 years. Here we have the effects of participation in the labour force due to a reduction in the occurrence of ischemic heart disease due to reducing the prevalence of those same risk factors. Here we see the same increases as you add additional risk factors in there. And we can report this economic measure in terms of both person years of work foregone, which is in the tens of thousands, and also the financial value of those years of lost work. And it's not surprising that you start to get some fairly large sums here, because you're talking about hundreds of people that are exiting the labour force compared to people without the disease for multiple years over that 15-year time frame. And here we have the final economic measure that I'll be presenting today, which is the production loss due to premature death as it relates to ischemic heart disease. And here we can report things in both the years of productive life lost, that is up until normal retirement age, and the financial value of that of those productive years lost. And here we can see when you reduce both BMI, blood pressure, and cholesterol at the same time, that's worth 400 million in financial value of productive life loss that otherwise would have occurred without that reduction. So I think there's some key advantages to this model based on the economic measures that we've included so far. The first is the underlying modelling approach that the other presenters have already spoken about, such as the system dynamics approach, the fact that there's multiple risk factors included in there, the interactive interface that Hytham spoke about, and the fact that users can do scenario analysis according to what's important to them. In terms of the economic measures that are included in the model, I think the fact that we can look at healthcare costs by area of expenditure, whether that's public hospitals, private hospitals, primary care, I think is one of the real advantages of this model to see how the risk factor reduction impacts each of those areas of expenditure. And we move beyond just healthcare costs to look at wider societal costs and different measures of productivity. And here we've included absenteeism, participation in labour force, and years of productive life lost due to premature death so far in the model. And the other advantage of this model is that we can focus on a specific sex, on particular age groups, if that's what's relevant to the decision-making context. Now, there are some limitations to the model. There's limitations to every analysis and every economic model, but hopefully what matters is whether it's useful or not. So the first thing to note is that it's not a cost-effectiveness analysis in the sense that we haven't currently included an actual intervention along with its cost and the actual intervention effectiveness in terms of the ability to reduce risk factor prevalence reduction. However, because of the structure and the foundations that have been set up, that kind of thing can be bolted onto the model in the future. The other thing worth noting is that there's a whole range of different types of economic measures that could be included in the model. And so we've tried to include what we think are the most important. Some are more easier than others to include in the model, but really it depends entirely on the decision context and what you're going to use the model for. So for example, and please excuse the jargon that I'm about to use over the next minute, some people in the core might have seen economic analyses that apply a financial amount to the health effects or improvements in length of life. Which is often done in cost-benefit analysis of infrastructure projects, for example. It's also done in the healthcare sector where quality-adjusted life years, if you've ever come across those, are monetized as well for an overall financial benefit to trade off against the cost of implementing something. Now, how or whether this is done in the model depends on whether it will be used to inform budget allocation across the entire government portfolio, for example, or whether it will be used to fund, local prevention intervention. And you just need to prioritize which of those interventions at the local level will be prioritized. It's less important to do that in that scenario. Another example that's of something that's not currently included is unpaid work. So the model currently favours those risk factors and diseases which are more likely to occur in people that are in paid employment, such as middle-aged people and particularly men. So once again, this is only an issue if your decision context relates to children, for example, or older people that are already retired, for example. So we are very interested in the upcoming Q&A session and the discussion to hear from you when and where you think you'll use this model and the kind of decisions that you think it will be most useful for, because that will guide the future inclusion of any other economic measures. So I'm going to stop sharing my screen now and pass over to Jackie, who will go through the final part of the presentation.
Thank you, Paul. Hello, thank you for that. Screen sharing, hello.
Yeah, we can see that, Jackie, that's fine.
You can see this going? Yep. Great, thank you for confirming. Yes, I'm just going to quickly go through the remaining steps that we have to do on this project. We obviously have been at work on this for the best part of 2020 or 2019 and 2020, I should say. So we're still at the process, the point of model validation and calibration. That's the bulk of the work that remains at this point in time and what we are focused on. However, we've still got one disease we've left the best till last, or the most complex probably till last, and that's type 2 diabetes. And we need to be inputting the prevalence, incidence, and fatality data for each age and by age and sex for diabetes and the sequela for those. So we're also looking at, as part of that work, looking at historical disease, making sure that we've got consistency between diseases from 2003, from the first ABD through to 2015. We're also just ensuring that we've got consistency between our data sources in relation to disease expenditure and disease prevalence, and making sure they're aligned. We're also doing, obviously, our work to the future, to the remainder of this project in 2021, as we're looking towards next year, is finishing this work, but working further on the online dashboard, which you saw the sort of pro forma of it that Haytham demonstrated in his video. So we need to work on that, and we'd like some feedback on that from you, the policy partners who have funded this project. We would be most pleased to be able to find ways for you to contribute online by sharing, as we can, find ways to show you some screenshots or set up a small, working online session to do that. And we do hope to be able to release the model to partners, as Andrew noted back in his introduction earlier by April of next year. So there's one piece of work which is also about improving the model efficiency. I think Haytham also alluded to that, and the complexity and Danielle, the complexity of this model is such that yes, we have limitations in terms of how to make it run in real time at the moment, and we've got to find ways to improve that. So it is a useful online tool. That's its objective. So with that in mind, I would just like to let you know that I'm going to be sending out a survey form in the next week. Either late this week, early next week, with some of these questions, and seeing if you hopefully get some responses back about who would be interested in, providing some feedback, just both on our presentation, of course, but also on the work to date, and how you think we could improve both a representation of economic indicators, as Paul mentioned earlier, and the online dashboard, how we can make that a more user-friendly tool for all of you. So I've just put up our contact details here. I'll put them up at the end as well, at the end of the session. So if you don't catch them all now, we're also obviously in the Teams chat here now. You can contact all of us via that. And and I think I'll leave it on that. And I think I'll stop my screen sharing now, and I'll be passing over to Lucy. Professor Lucy Rachetnik is the co-director of the Prevention Centre, and she is online as well, and she'll be leading the questions, the Q&A session, and hopefully you've got lots of questions for you. We've got about 20 minutes of questions, question time, I think, before we need to wrap up, so I look forward to that.
Great, many thanks, Jackie. So good afternoon, everyone, and thank you so much for joining us today. My name is Lucy Rachetnik. I'm the other co-director of the Prevention Partnership Centre, and thank you so much to all of you, Joanne, Danielle, Haytham, Paul and Jackie. What a fantastic piece of work. So we've got, as Jackie said, we've got about 20 minutes, so we very much welcome any comments or questions. So there are two ways to ask questions. Either to put them into the chat, which Jackie will be monitoring, and she will read out questions. The other option is to put up your hand. So I can see the participants here, and if anyone does want to ask a question, please put up your hand and then unmute yourself, or I can read out the name and Jackie will unmute you. turn on your video and maybe just say, introduce yourself just so that we know who's speaking, because this is being recorded and we'll be sharing it with the people who weren't able to attend. So if people would like to join and turn on their videos as well, very welcome to do that. It'd be nice to see the participants as well as our presenters. I don't know if Bernie is still here, but Bernie, you mentioned in the chat earlier about dementia and a comment about that it was important to include it. So I don't know if anyone from the team just wants to. I know Jackie, Danielle, rather, you mentioned that dementia wasn't included. I wonder if you could just comment again on the reasons for that. And maybe just Bernie, if you wanted to make a comment first. Or
look, thanks, Lucy, and I'm just struggling to turn my microphone.
We can see you.
They can see us now. There's my colleague is Leanne is here as well. I was just, and you're very sharp to pick up on that, and I don't want to dominate here, but there are a lot of common risk factors for dementia, and that evidence base has got stronger and stronger. So I was just surprised that the comment was that I think it was that we don't know enough about that. And certainly I worked in aged care in 2019, and it's such an important condition and in elderly people, but more broadly in terms of its human cost and financial costs. So I just was surprised that it had been dismissed, but perhaps it's for further down the track. Yeah, anyway, over to you.
Joanne, maybe, and then Danielle. Or...
Sure. No, and you're absolutely right, Bernie. I think this is, the evidence is certainly maturing in this space. I think we were relying heavily on the mature nature of the evidence in the other areas and the focus on what the burden of disease study had articulated. But I think you're absolutely right. This is, a substantial and growing burden with the evidence becoming stronger. And I think this is definitely probably top of the agenda for future for expansion work. We needed a lot of estimates in order to put into the model, and sometimes when we don't have too many of those estimates quite solid, it can become really quite rubbery. But I think definitely this is a maturing space, and will come in. Yeah.
Danielle, did you want to add anything?
No, I think Joe said it very well. It was simply that the evidence, as Joe said, is maturing. And when we first started kind of compiling the list, we didn't have the same level of completeness of the evidence. And so when we were making the list at the beginning, it didn't make the cut. But I think for any future kind of iterations of this, it's definitely one of the ones that we recognize needs to be in there. And so, yeah, it's top of the list for the next iterations of this and for any kind of future work we do.
Right, thank you. I noticed there's a question in the chat, and probably for you, Paul, from Natasha, saying, can you clarify the level of granularity or aggregation that can be achieved when looking at the economic data?
Okay, so in terms of the healthcare costs, we can go down to area of expenditure and by age and sex. And that's, in large part to the great work done by the AIHW for the underlying disease expenditure estimates. In terms of the other measures, we can go down to particular age and sex groups as well. So if you're looking at an exercise intervention for young women, for example, which I think it might be something that GoHealth did recently, we can focus on those groups. I'm assuming that's the level of granularity you were talking about.
Natasha, do you want to come online and elaborate? Did that answer your question, or was there any further detail that would be useful?
No, that was great, thank you. And I guess just following on from that, you mentioned that obviously those costs might not be useful if working with children and young people, etc. What other thoughts, I guess, for that age group and further work in that space? Because for us in South Australia, the early years are of particular interest.
Yeah, okay, so I should probably provide a bit more clarification around that. We have costs for healthcare costs for all diseases from the age of 15 onwards, And what I was referring to there was more about some of the productivity measures. So someone has to be working before they can have a productivity impact due to not being able to work or exiting the workforce. Now, there are methods by which we can account for people that aren't in the workforce and the kind of contribution they make to society and the economy through unpaid work, such as volunteering and informal caring for other people that are sick, for example. Those things do have productive value. They're not currently included in the model, but can be if it's critically important. In relation to your question specifically about children, I guess what's already in the model and what can already be accounted for is what happens when those young cohorts become older. So if they currently have issues with any of the risk factors, whether it's obesity or their propensity for physical activity or to develop high blood pressure in the future, we can already reduce those things and what can happen in the future. So as much as someone might be a child at the moment, if we stop them getting disease 20 years into the future, that can already be accounted for in the model, both in terms of the health impacts and the healthcare costs, and whether or not they are working due to getting that disease or not into the future.
Great. So it's just more a matter of like how we use the data for our benefits in terms of how we're pitching it more so.
Yeah. So I mean, I guess you could look at you could potentially look at a scenario of here's your current trajectory of obesity in children as it currently stands in South Australia. Now let's reduce that by a little bit and see what happens to the cost of ischemic heart disease or all diseases for all health expenditure and by area of expenditure. How does that affect the health costs over the next 20 years? You can already do that with the model.
Great, thank you.
I should add just to that, Lucy, that or should I guess note that the model really focuses on people who are 15 plus. We made that decision at the beginning of this project because the risk factors that affect children are quite different to the risk factors that affect very young children, are quite different to the risk factors that affect individuals who are over the age of 15. And since we were trying to limit the risk factors to the ones that contribute to the greatest burden in terms of the whole Australian population, we left out kind of neonatal and birth-related outcomes and things that are really related to young children. And so that was just a decision we made for simplicity's sake. But because of that, it's probably not the ideal tool to look at interventions and problems related to young children, more burden related to the adult population within Australia, the 15 plus population in Australia.
Great, thanks, Danielle. There's another question from Emma Lonsdale, and I think again for you, Paul. What's covered in the lost productive years due to premature death?
So essentially what we're doing there is if someone was going to work until the age of 67, but they die at the age of 60 instead of 67, there's 7 years there that they could have otherwise worked. And so we have a basic measure of that 7 years of lost productive life, and that's by age, sex, and disease. And then we apply a financial value to that. At the moment, we're using the proxy of employee income, which we have extracted from the Survey of Income and Housing from the ABS by age and sex. And so at the moment, it kind of represents more of a personal perspective, so what that person otherwise would have earned, but sometimes that measure is used as a proxy for the productive capacity that person would have contributed to the company that they worked, their employer that they worked for, and the economy in general. But here we're starting to get into some of the technicalities around how economists treat productivity measures and the different financial amounts that are applied to those.
Thank you. Emma, does that answer your question?
Yeah, quite a lot. I was just a bit confused about, I guess, the participation in the labour force versus the lost productive years. So if someone is working up until retirement age, and how it differentiates. So I think it sort of answers it.
Yeah, well, we can only the model, the way it's structured at the moment, can only accumulate lost productive years when they're not working if they're alive, and then if they then die related to a particular disease, that's when the other measure kicks in.
J3, I just noticed J3's also joined us. You've just popped up on my screen. Hi, J3, welcome. J3 is the other health economist. I just wondered if there was any, if you wanted to make any additions or comments to what Paul's already said. Any reflections from you?
Just to add to Emma's question, that if someone's still in the workforce and still their loss of productivity is captured in absenteeism as well until they leave the workforce. So you do get that period where they might be still in the workforce but not productive, or reduced productivity because of their absenteeism. Does that?
Thanks, J3. There's another question here, and again, it might be for you, J3, or for Paul, from Carmel Williams from South Australia. So, Paul, you mentioned that the productivity measures did adequately account for people who were not in the workforce. Is there any thought to how this might be able to be addressed to ensure that the model doesn't unintentionally lead to policies that increase inequalities?
So the first thing that I'd say is that those people are still accounted for in the health benefits and the healthcare costs, and so those things should still be used for decision making. The productivity measures are kind of a bonus, but in terms of putting in accounting for unpaid work, it can certainly be included in the model. I guess with the long list of various types of economic measures that we could include, we kind of needed to prioritize what's included and what's not included, and that's a combination of ease of including into the model, certainty in terms of the input data that can go into it. So for example, it's relatively straightforward to establish the employment status of people and the disease that they have from the National Health Survey. It's going to be less straightforward to establish the productivity impacts for people in unpaid work, but it can certainly be done. Yeah, we would just need some time and resources to work through that if that's seen as a critical priority for our partners at the Prevention Centre.
J3, did you have anything to add?
Just to add that, as Paul said, the productivity impacts really should be as an additional result of the modelling. It and needs to be, the results without those impacts should be considered in decision making as well. And it actually includes things like gender-free wage rates to try and take into consideration some of those equity impacts of differential participation and wage rates by gender, but yeah, as Paul said, it doesn't include that unpaid productivity impacts yet.
Carmel, does that answer your question? Any comments?
I guess I think I understand what Paul and J3 are saying, but I guess we do know that policies are made and economic work and employment are incredibly important drivers in government decision making, as is healthcare cost. But if you're really wanting to have this model speak to wider government agencies, I guess I think it's important to be careful, I think, not to unintentionally provide a tool that will help policymakers continue on making the policy decisions that grow inequalities in our society, because that's what's happening today. And I just think it's just one of my concerns. I understand it's complex and difficult, but I just feel like it's something worth thinking about.
Great, thank you so much, Carmel. Any comment, Joanne? You look like you might say something.
Oh, no, I was just, I absolutely agree with Carmel, and that would be a terrible thing in my mind, that we spend 2 years working on a model that provides a tool to enhance inequalities. And I think it's good that Carmel raised that issue, so we can have that at the back of our mind as we're starting to test the model and look at the the insights that are coming out of it, and make sure we're properly documenting the limitations and exploring how we can advance the work in the future, and perhaps exploring broader perspectives for presentation of the economic outputs, and maybe even bringing in some aspects of social productivity. But anyway, that's another conversation. But I think it was an important issue to raise that we should definitely keep in the forefront of our minds.
I agree. I think it's really important to be very explicit about what the model can and can't do, what the limitations and what questions it can and can't answer, and some of the potential risks associated with relying too much on just one tool. There's another question here. Is there a cost in your model correlating loss of productivity due to caring duties for young, unwell children or the elderly? J3 or Paul?
Not at the moment. As Danielle mentioned, the model is focused on the population from 15 years and older. So I guess it would be difficult to add specific costs relating to people at under that age.
Isabel, did you want to make a comment, or did that answer your question? Any other thoughts?
No, thank you. I'm actually realizing the limitations of your model, but it's a wonderful tool. It's just that I was particularly thinking about the trajectory of life, and the fact that a lot of people face the situations in life where they need to actually care for others, therefore they need to take themselves out of the paid workforce. So that is actually quite significant factor, I would imagine. And as we know, carers in particular contribute enormously to the economy. And I would imagine that would need to be actually taken into consideration. There are some studies done on evaluating the economic cost of carers' input. So I think it's important.
It's absolutely critical. Yeah, I completely agree. But I guess with any model, you need to set boundaries at some point
yes.
about what's included and what's not. And
yes.
I can tell you at the moment, there's a lot that is included in this model.
I understand. I just sort of think that you need to also look at the sort of the size of the economic injection into the economic size of the contribution of the carers, which is quite significant. So just wanted to put it out there.
Yeah, there is absolutely precedent and methods for including that kind of thing, and so I think that's probably something we need to take away and have a look at the possibility of including it here.
Right, many thanks, Isabel. J3, anything else you wanted to add on that issue?
No, I think it's just highlighted something that's on the top of the list of additional things that might be able to be added to the model at some point is these unpaid productivity impacts.
It's a bit of a growing list, isn't it? The things that could be added to the model. And there's another comment from Bernie. So just wondering about the next steps in terms of intelligent interrogation of the model, the questions to use, best evidence of the effects of intervention across populations. Bernie, do you want to elaborate on that?
Yeah, sure. And sorry, that probably is a rather acute question, but I guess I'm just sort of outing myself that I've got our interest here as policymakers is and it may be jumping ahead. It looks really interesting, and we've just had a brief demonstration today of if you do this and this, 2 different types of combinations of risk factors, what impact it will have further down the track. But for us, we're sitting and thinking, so for example, you would know very well that we've got about to put out to consultation a national preventive health strategy. So our interest then is what this could be really useful for, I'm sure, to think about, based on an evidence and modelling like this, what are the priorities for investing in going forward in prevention. And so to me, there's a bit of a gap then to what you've demonstrated today to how we intelligently use the model. And it's almost like we need you to teach us how to ask the right questions and to use the model, or perhaps that's going to come over time. We've just had a brief discussion today and a brief kind of demo of it. But I'm not sure if you're... So to me, there's still quite a big gap for a policymaker to use this to intelligently inform, say, purchasing decisions.
Yeah, that's really valuable, and I know the team are definitely keen to, when the final model is finished, to have a sort of a rollout of workshops talking to end users about how it can be used. And Jo, I'll hand over to you. Sorry, I jumped in. You were about to respond to that.
No, sorry, I wasn't respecting the process. Just jumped in. No, and I think this is really important, because the point is not for us to give people the answers. It's to give the tools to be able to ask the questions that you face every day. I've got this broad list of risk factors, and normally we kind of say, well, let's tackle it all, which, in reality is not necessarily feasible. So how can we be more strategic? Do we need to reduce, alcohol do we get the biggest gains by reducing alcohol consumption by 10%, smoking by another 2%, childhood overweight and obesity by X%? What combination of those things at what scale? And asking those questions also kind of brings in value judgments of decision makers, and also, questions of feasibility of what we can actually achieve. And I think it's a conversation, but it's a conversation that's had over, a model that brings together the best available evidence and data that we've got, and able to look forward and say, well, if we do X, Y, and Z, what can we expect in terms of impact, and is that enough? Do we need to do something different? And we're just using a method that has been successfully used to manage the COVID pandemic. Australia is in an excellent position globally because decision makers work together with systems modelers to develop the tools, or to bring together the best information and ask a series of what if questions. Had we have not gone to the extent or the scale of certain lockdowns and got the timing right, we wouldn't see the success we've seen today. So we want to empower decision makers with these same tools in chronic disease prevention that have been successfully used in infectious disease control.
Right, many thanks. And I realise that we've hit time. So unfortunately, although I'm sure we could have this conversation for much longer, we'll have to bring this to an end. So I really want to say thank you to the team. It's been a fantastic piece of work that you're doing here. It's really exciting. Thank you so much to all of our funding partners. It wouldn't be possible without the funding partners who support the work of the Prevention Partnership Centre. So thank you, Joanne, Paul, Danielle, Haytham, J3 and Jackie for coordinating the team. As we've mentioned, the final model will be launched in the first half of 2021, and there'll be a series of workshops. As Joanne said, this is very much about a tool that supports dialogue and conversation, and I think that's really important. Also, as Jackie mentioned, she'll be sending out a survey, so we really would value your feedback, your comments, particularly about what questions, what measures are most important, because as Paul said, we do have to make decisions about what's prioritised and what is included. We also just wanted to acknowledge Jeff McDonnell and Mark Heffernan, who were very much involved in the conceptual design of this in the first phase, so thank you to them as well. I think it's time to say goodbye and thank you. So well done, everyone, and thank you so much for all of you for joining us. Okay, bye.
Bye, thank you very much.
Thank you.
Thank you all.